This is the Intraoperative Keratoscope mount, which is fixed onto the Leica microscope. The Intraoperative Keratoscope is unmounted. It is fixed onto the base of the keratoscope. You can see that the green mark in the keratoscope coincides with the center of the mount. The keratoscope is rotated anti-clockwise till a click is heard. The Intraoperative Keratoscope cable is connected to a power supply and you can see the ring light being switched on, ready for the surgery. Case 1. This is the preoperative anterior axial map of a keratoconus patient. So this is the CAIRS planning tool which is there online. Depending upon the cone for each and every patient, you can design the tissue size by entering the parameters in the planning tool. Once this is done, you can have this as a reference during your surgery. After doing a femto cut, the tunnels are opened. The channel is dissected both up and down. This is a pre-prepared customized tissue. We usually dry it for 2 to 3 hours so that it becomes really hard and the insertion is pretty easy. You can see here, just like an Intax ring, the tissue is being pushed in to the desired position. So care is taken that the tissue does not reverse or get twisted. So once the final tissue is being pushed in, a curved Y rod is used to manipulate the tissue. Once the tissue is placed and it is tightened, Intraoperative Keratoscope ring light is projected. You can see that there is a little bit of irregularity, so I am trying to tighten it and loosen it in the upper and the lower portion. And now what you can see is a perfect ring. The epithelium is scraped off and the riboflavin drops applied. Once the UV light is passed, the tunnel is closed with a glue and a bandage contact lens is applied. This is the 1 week post-op where you can see a very uniform flattening happening both superiorly and inferiorly. This is the post-operative comparative follow-up. You can see that the preoperative K reading is 55.4 and within a week after the CAIRS, you can see it coming down to 43.4, showing almost minus 13.2 diopters of flattening. The point to note here is there is a uniform flattening with the help of an Intraoperative Keratoscope. There has been a tremendous improvement in the visual acuity at 1 week, and you can see that from the preoperative uncurrent visual acuity of 660 improved to 624. At 1 week, changing to 624, the uncurrent visual acuity with a correction improved to 69. Case 2. This is the preoperative anterior axial map of a keratoconus patient. So this is the CAIRS planning tool which is there online. Depending upon the cone for each and every patient, you can design the tissue size by entering the parameters in the planning tool. Once this is done, you can have this as a reference during your surgery. The ring light is projected, both the incisions are opened, and a curved Y rod is used to dissect 360 degrees. It is opened 360 degree to facilitate the insertion of the tissue. The pre-prepared and customized tissue is now inserted and pushed into the tunnel. Care is taken that the tissue is not distorted or twisted when it's being pushed or pulled. With the help of a reverse key, the tissue from the other side of the incision is pulled. The light is again projected, but you can see that the Myers are not very regular. So I'm trying to adjust the tissue to see. Again, I am not happy with the ring shape. So I am trying to trim the tissue so that I can loosen at one end and I can tighten at the other end till the perfect ring is achieved. Now you can see that the ring is almost round and the desired shape is achieved with the help of the Intraoperative Keratoscope. The epithelium is scraped off and the riboflavin drops applied. Once the UV light is passed, the tunnel is closed with a glue and a bandage contact lens is applied. This is 1 week post-operative following CAIRS, where you can see that the cornea has become more regular and flattened. This is the follow-up comparative anterior axial curvature map. You can see here that preoperatively the K reading was 53.74, coming down to 48.20 at 1 week. Almost about minus 5.4 diopter of flattening is seen. Point here to note is that you can see there is a very uniform flattening which is achieved by using the intraoperative keratoscope. You can see that there has been a tremendous improvement in the visual acuity. At 1 week, preoperative vision from 3/60 uncorrected improved to 624, changing at 1 week with the uncorrected visual acuity improving to 618 and with the correction to 69.